Sam Marshall shares uplifting stories and conversations with people making Johannesburg and the world a better place.
And that's what we do. We keep on having these amazing conversations, as South Africa, Africa's only social impact radio show. Can you believe it? Mondays to Fridays, 9 to 12. We're the only show in the world that focuses on CSR, shared value, social innovation, social capital, and ESG. And it's no different. We're deep diving into the complex but urgent space of healthcare access, equity, and corporate accountability, with cardio, kidney, and metabolic conditions rising sharply across South Africa and Africa. The question isn't just what's being done, but who's doing it, who's boldly, transparently, and for all the right reasons affecting change. Now, joining me right now in studio, very busy man. He's made the time to come in studio. It's Thabeng Lipeng, who's the Director of Market Access and Public Affairs at Novo Nordisk. And he's going to talk about the role that the organization plays, and specifically himself as well, at the intersection of policy, public health, pricing, and purpose. Thabeng, thank you very much for joining me.
Thank you, Sam, for having me. Thank you for the invite. I look forward to the conversation.
Yeah, this past weekend, I was privileged with a bunch of journalists to go to a conference in Cape Town that really looked at, for me, and as a journalist, I was sitting amongst all these learned doctors and professionals and esteemed medical colleagues from all over the continent. And the word, well, there was two words. There was the word diabetes, and then there was the word obesity. And I'm going to be honest with you, until we had the presentation from the doctor who's based in Germany, I never thought of obesity as something more complicated than just this choice between whether I eat or don't eat. I did not think that there was so much that went into this idea that obesity is not just very, very serious, but there are medical underlying conditions and factors outside of the control of the person who's suffering from obesity that is more than just a lifestyle choice.
See, thanks for that question, Sam. It's really something that we've been grappling with for a while now, because for someone that is obese, there's a lot of stigma around them, and there's a lot of people would say that these kind of people that struggle with weight management should just eat less and exercise and move a little bit more. But we know from science that this is not just from a typical dietary issue. This is really something that can go beyond just food. It is genetic. It is something that's got to be addressed.
Which blew my mind.
As a chronic disease. And lately, in fact, we've been going beyond just recognizing it as a chronic disease, but also recognizing it as a treatable disease. Because it's one thing to establish it as a chronic disease, but can you treat it? And now we know that we've got treatments to treat obesity, even in South Africa. And that's what CKM was all about, right? CKM
cardio, kidney,
was
metabolic,
a coming together of HCPs and colleagues alike, from policy makers to payers, to patient groups as well, if you like, who were invited to be a part of this meeting. And the reason we've invited all these colleagues was to come and share in this knowledge sharing session where we talk about the burden of obesity, not only in South Africa, but broadly in Africa as well, because you would have seen that there were colleagues invited also from just outside of Africa as well, right? So it was broad Pan-Africa meeting as well. And so CKM, cardio, kidney and metabolic disorders are now at the intersection of burden of disease in South Africa, and this is why it's important and timely that we begin to have these discussions right now, so that we can curb the rising of NCDs in this country.
I think the other challenge also that for me was also kind of this watershed moment where another presentation that followed the doctor from Germany was, I think, was an Egyptian-based doctor, and he then lays out what the landscape looks like in terms of a couple of years ago, for example, there was very little understanding of obesity and its impact, and a large focus was on diabetes, and diabetes for the longest term has gotten the medical recognition, the kind of level of training, the insight, the understanding, and then obesity was just the stepchild, and now there's been this massive shift to understand the impact of obesity on people's lives and how it impacts their kidneys, their ability to function. But it's taken almost a retraining for kind of the industry to understand the differences and to elevate the almost the classification of obesity as a disease and not a lifestyle choice.
Right, and hence the great work that we need to do. With policymakers to begin to recognize it as such, right? And as someone who's responsible in Novo Nordisk for both market access and public affairs, this is what I get up to do every single day, to meet with payers, to meet with government officials, to discuss how do we actually begin to look at obesity as a treatable chronic disease, and how do we actually collectively work to make sure that all these patients can access some level of treatment for these diseases. It's not that we're looking at obesity as a standalone, we're looking at obesity as part of the NCD. So a lot of the time, obesity is referred to as a gatekeeper disease to the four major NCDs in South Africa that we're grappling with. You know that in this country we've had a burden in the past of HIV and TB, right? So we had a big fight to fight the communicable diseases, and now the fight has kind of shifted to the NCDs. And if obesity is a gatekeeper disease to these NCDs, then that already tells you that if you deal with obesity, you kind of already deal with the complications of it, which result in early onset of diabetes and the likes, and some typical cancers as well. And so this is why this discussion has become so important for us to begin to make sure that both payers and public, look at obesity as a treatable condition.
There was, I also want to talk about potentially the idea of health equity, because I think it's, let me just clear my throat there. This idea that Novo Nordisk has really created the opportunity and the platform for people to be able to engage and have this conversation. And so I want to understand kind of the health equity of it and kind of why that has become such a huge focus for Novo Nordisk. And what does that mean for us as laymen when you guys, the experts, talk about health equity?
So health equity is a division within global Novo Nordisk. Health equity means a lot of things. It means prevention, but then it also making sure that treatments are available to, all the patients that deserve these type of innovations. And so part of the health equity work that we've been doing in South Africa in the prevention arm has been a public partnership that we have signed and come into with the city of Johannesburg. It's also been supported by the MEC for Health in Gauteng, which is basically dealing with obesity in the schools. So this is almost a pilot study that runs for 3 years that we've started last year.
And that's a big story, by the way. It's a big story that you've now partnered with the city of Johannesburg. And you are looking at obesity at a school level.
Yeah, we actually had a signing ceremony on this already last year and this year also, both with the province and then with the city as well, where we look at childhood prevention initiatives, or rather childhood obesity prevention initiative within the schools, about 20 schools that we are doing this work with around Johannesburg. And we've got between now and up to 2027 to wrap up this study to begin to understand better what are the contributing factors to children, dealing with weight or obesity rather at this early age between the ages of of 6 and 13. But then we're also looking at why is it that we're having early onset of type 2 diabetes in school going children as well. And this is why we do this work, and it's a pilot in Johannesburg, but looking at how that pans out as well, we could be looking at scaling it across the country. And that's some of the health equity work that we're doing within that space. But if you go on to diabetes, for an example, for a long time, Novo Nordisk has been, a major contributor in terms of the supply of human insulin to the state. We're continuing to do that. To this day, we're still supplying human insulin to government. But, one interesting development in the past month has been that we have managed to secure a lot of supply of modern insulin analogs, which is basically innovation that's always been available to patients in the private sector who have some level of private health insurance, right? But if you are reliant on the state sector, it means that you haven't had an opportunity to access such latest treatments. And now they do. We worked with government, and we made sure that we secure sufficient supplies to make sure that patients who struggle with type 2 diabetes are able to access more than just human insulin, but also analogs now.
Yeah, and in the midst of that insulin conversation, there are many things we can pick up there, but it's also the transition from pens to vials and all of that kind of stuff. But I kind of want to specifically stay with one topic around this idea that this health equity now provides opportunity for us to all learn in real time, right? And so this idea that we've got all these experts who attended this conference, and through the other interventions before that, there was the conversation in Chicago as well, where Novo Nordisk was involved in as well. How important is it from a market access perspective that, yes, we're having the conversations, yes, they're the innovations and the technology, but that we don't leave the marginalized out of the conversation? Because it's very easy to focus on urban areas where resources are in abundance, and it's a little bit more difficult to think of rural, where sometimes there's one clinic to a community. Sometimes, in some instances, we've seen interventions like with Johnny clinics, empathy clinics, and all these other guys coming in, but it's still not at the rate where it should be. And now we're talking about the idea of a nurse entrepreneur who's slightly different from a doctor. So when we talk about market access, how important is it to be truly inclusive?
So that's a great question. And so it's important that as a supplier of medicines to the government of South Africa, that we consider the beyond treatment approach. So it's not good enough any longer just to supply the medicine on its own, but to make sure that it reaches the people, especially those ones in the underserved areas or in rural communities in South Africa. And one way of doing that, right, because as one company, we're not going to be able to do it all, but this is where these private-public partnerships come into play. And we rely a lot on our partnerships that we've got with patient groups. We do have a really good relationship with SA Patient Advocacy, for an example, on diabetes. We've got the Diabetes Alliance, we've got Sweet Life, for an example, just to name a few patient groups around diabetes who we do a lot of work with. And this is really just around creating awareness and creating education also around diabetes, looking after, for those signs and symptoms, to be able to get people into the system a little bit early so that they are able to access these treatments. But also more than just that, right? It is also making sure that we support the training. Part of our discussions that we've been having with government was to make sure that we provide capacity and capability training opportunities for the nurses in state as well. And so I've got a team, in my division also at work that goes out into provinces, to work with institutions. So these are the central hospitals who basically invite the drainage areas as well. So if you are in a large hospital, for an example, in Gauteng, you've got a referral clinics that refer patients into you. So we make sure that we also invite those nurses also in those surrounding areas to be a part of the conversations, to get the latest training on diabetes, so that they are armed, with the knowledge that they need, that they can pass on to patients as well. Because patients require ongoing education. They require, knowledge so that they know exactly how to understand the disease and, be able to live quite safely and healthily with the disease. And so this is the work that we do through these partnerships that we've set, to make sure that nurses are capacitated and they've got the capabilities also to pass on these insights to patients.
As we know, and as you know, ESG is more than just corporate speak, right? It's about people, trust, and impact. Now, how are you, especially you as the leader, as the team, how are you making sure that those principles are shaping decisions here in South Africa? Because obviously it is a global company with its own ESG outlook. But what does that look like in practical sense in South Africa?
Yeah, so this is again very heartwarming type of work, very meaningful type of work that we've had the pleasure to do in the last while. And so I can use an example of your question you're asking, a clinic in Alexandra that we have partnered with from about 2 to 3 years ago, when we decided to launch Cities for Better Health as an initiative under the Global Health Equity umbrella as well. And so we used to actually call it Cities Changing Diabetes. And then because of obesity also rising as a burden, and as an issue that needs to be dealt with, we decided to change the name from Cities Changing Diabetes to Cities for Better Health. And as part of that initiative, what we did is we partnered with River Park Clinic, which is situated in Alexandra. And what we did there, we basically contributed to implementation of the food gardens on the premises of the clinic. And we made sure that patients who are impoverished, and are not as lucky as you and I, for an example, would be able to access those food gardens to be able to have some food, because you can't be taking diabetes treatments. On the one hand, you're also not feeding yourself properly and in a healthy manner. And so this was one way of dealing with, basically hitting that bird, with two birds with one stone, right? Yeah. Because what we're doing is you are providing healthy eating and you are educating on the correct way of eating, but at the same time you're providing the well needed nutrition to these patients.
There's also other knock-on effects. Like, for example, you would have to, from a localization perspective, you're training local people to look after those gardens. So there's this kind of really nice circular shared value model that kind of threads its way through there.
We had actually agreed with the security guard there.
You told me. I love that story when you told me about it, because I thought it was a great secret that you guys kept.
It's not meant to be a secret. But we don't go out and talk about these things as often as we should. And the idea, is to replicate that model, because it really does work. I mean, the security guard at this clinic does look after the garden, helps us look after the garden. Yes. But also because we partnered with a group of young people called Yard, in agriculture, and they came because they're really students also at the University of Pretoria, studying these things, and they came on, to work with us, and from time to time, I think it's once a quarter, if I'm not mistaken, that they actually go back to the facility to make sure that the garden is still what it should be, and also to give tips to the staff working there to make sure that they know how to look after it.
And not to put you on the spot, but you know how many people the garden is feeding at the moment?
I have no idea how many people, but it's basically that community that is reliant on that clinic.
That's amazing.
So anyone that fetches their diabetes treatments from that clinic, they go in and they get their treatments. But before then, the head of diabetes clinic there, is also quite invested and very involved in the program. And so they make sure that when the patient come in, they get exercise outside. So that's where it starts with the aerobics, of just to instill that mindset of active lifestyle. And then they can go into the clinic and fetch their treatments and get their blood tests done. And then just before they head back home, they can go at the back of the clinic to collect their food from the garden and then make their way home, which is really good. Yeah.
As we wrap up, I want to come back to the CKM Africa Summit that now concluded. As a final question, two big things came out of it for me as a journalist sitting there. One was that the increase in funding in studying in terms of the impact of diabetes is on the increase. More and more experts are now moving in that realm. If you can, but you do an analysis of 5 years ago versus now. There seems to be wanting to be a better understanding of the impact of obesity, versus diabetes. What does that look like? What does that war on obesity look like in the next 5 years? Are we going to see an increase of funding towards the studying of obesity? Are we going to look at a reclassification of obesity as a disease and the orientation for medical professionals to move away from the idea that it's somehow just lifestyle treated? Are we going to see more education amongst the public? What does the war on obesity look like in the next 5 years?
So between now and 2030, there is a strategy, right, to begin to lobby a little bit more. Work with governments a little bit more. And I say governments because this is a global thing. It's not just in South Africa. But if I bring it back home, we've just had a meeting 2 days ago, for an example, engaging with the Council of Medical Schemes to begin to understand, what is their position on obesity as a chronic disease. Because remember, in South Africa, we talk about things referred to as PMBs, which are prescribed minimum benefits. So the Council of Medical Scheme decides on these conditions, right? Diabetes is a part of those conditions, your hypercholesterolemia. So the bulk of your NCDs are included in those 26 conditions that are deemed as the prescribed minimum. So basically, if your doctor has diagnosed you with any of these 26 conditions, your medical aid must provide the treatment and the care. But obesity is not seen as part of these, yet obesity contributes greatly to all these 26 conditions that have been listed on there, including mental health as well. And so part of the work is to engage these policymakers, such as your Council of Medical Schemes, to say, are you planning to make sure that obesity is recognized as such? Because until such time that they do that, medical aids are not obligated, for an example, to basically put together some level of benefit to make sure that patients can access treatments of obesity. We have, however, been doing some wonderful work in this space where we've got some schemes that have agreed to do pilots, so they've actually made sure that they put together obesity programs that patients can begin to access those, and those are from an MDT point of view. These are multidisciplinary teams who are working with these patients. It's not just you and your doctor, but there's also making sure that we include a dietitian, for an example, a psychologist, for an example. So it's a team working with these patients, and there's some patient support programs as well that are being made available to these patients to make sure that they know exactly how to live with obesity. And this is why we refer to them as people living with obesity and not necessarily as patients, right? Okay. That comes from that standpoint. But the fight is to lobby policymakers, but also at the same time to make sure that the discipline is also understood, right? Because it's important that we continue to provide or rather contribute to the training. A lot of these scripts, for anti-obesity medicines would come from GPs, right? Yeah. But there's also an interest from the GPs themselves to make sure that they upskill themselves in really and truly understanding obesity and understanding how to treat it and how to also identify it in the patients. There's some press releases also that you would have seen. You're talking about the ADA. Yes. On the Step Up trial, for an example, that came up, trying to show, and if you look at the Step Up trial, basically that looked at patients without diabetes. It just looked at patients who are overweight or obese, and really just investigating treatments and seeing what type of weight loss we can achieve in those patients. But more than just the weight loss, we're now looking also at averting cardiovascular events, right? And not just dealing with the weight itself, because that's no longer now the primary, it's become the secondary.
There's just so much to unpack, and we've run out of time. But Thabeng Lipeng, thank you very much for joining me, Director of Market Access and Public Affairs at Novo Nordisk, talking to us about a very interesting conversation, and we're going to invite you back for a much longer session to unpack some of the work that Novo Nordisk is doing. This, of course, is on the back of the CKM Africa Summit that was recently concluded in Cape Town. And maybe you should just go to their platforms They can go to Novo Nordisk platform to see some of the outcomes of those conferences, but also what you as an organization are thinking around how people can management. There's lots of data there as well.
There is on our social media pages, but then also on our website itself. All of this information is available to the public. So anyone wants to engage with us, it's www.novonordisk.com. We also Novo Nordisk on Instagram, on Facebook, and on Twitter as well.